I am Meredith Hirsh, and this is Working Healthcare. Today, we tackle the question on everyone's mind. With a growing physician shortage, are the new doctors ready for real-world care? The American Association of Medical Colleges, the American Journal of Medicine, and the National Center for Health Workforce Analysis all project a cavernous national shortage of physicians. Some reports project a shortage of about 187,000 full-time equivalent physicians, with 31 to 35 specialties in deficit. The American Journal of Medicine estimates our current national physician shortage is already at 57,000 physicians. That avalanche affects every aspect of our $5 trillion healthcare sector. At the same time, the pipeline keeps swelling. The 2025 match was the largest in history, with more than 52,000 residency positions up for grabs, an unprecedented scale for training new clinicians. Note that roughly 6% of residency spots go unfilled on match day. And total medical school enrollment has climbed to near 100,000 students nationwide. Those numbers force an uncomfortable but necessary conversation. Volume is up, but are graduates ready? Money pressures the pipeline too. For the class of 2024, typical graduates reported about $200,000 in educational debt, with roughly 1 in 4 who owed $300,000 or more. For a 4-year medical school education, the cost pushes well past $280,000 at public schools and $390,000 at private schools. And there is delayed gratification. Depending on the specialty chosen, a newly coded doctor could face another 3 years of residency training to become a primary care doctor, or 9 years in combination with subspecialty training for thoracic surgeons. That puts the neurosurgeon at 35 years old if going straight through without any breaks or deviations. Debt shapes who applies, where they train, and what they choose to practice. Today's guest is at the forefront view for all of it. Dr. Allison Ferris is professor and chair of the Department of Medicine at Florida Atlantic University's Charles E. Schmidt College of Medicine. She directs the internal medicine residency program and serves as assistant dean for faculty development, roles that put her at the nexus of recruiting, training, and graduating the physicians who are in such high demand. We'll also tackle hot topics. What's truly driving the shift toward greater racial and ethnic diversity in physician training? What explains women's steady rise in medical school, and what still gets in the way? And elite undergrads, are they really peeling off to Wall Street, or is that just a loud myth? And students entering with the same preparation, are they entering with the same preparation as past generations, or are there different strengths, and does that require different training and teaching? What actually predicts readiness on day 1 of residency, and what should we fix in medical school to get this right? We'll talk straight about moonlighting, which Dr. Allison Ferris did, debt, and the real menu of career paths. And yes, we'll press on debt, admissions pressure, and whether July is actually a rough month to be in the hospital. Expect candid stories, practical advice, and actionable ideas for anyone who teaches, trains, or simply cares about the physician workforce. If you believe today's students are stronger than ever, or you're a little bit worried that they're less prepared than their predecessors, this conversation is for you. Dr. Allison Ferris, welcome to Working Healthcare.
Thank you, Meredith. It's a pleasure to be here.
I'm very excited about this conversation. I know that you work with internists and you work on the training with residents, but you are a professor, as I teach as well, and I definitely see a change in the students today than I did previously. But before I get into that, I really want to talk about why you decided to go to medical school and become a doctor.
It's a fun question. I mean, so I grew up in a very small countryside part of Western Pennsylvania, not even a town, dirt roads, farms, cows. We didn't have a farm, but they were all around me. And, to be honest, I didn't have a lot of contact with the healthcare system as a kid, knock on wood. And thankfully I was a healthy kid. So, I went to the doctor like once a year and, pretty much only when I had problems. So, I didn't have one of those compelling stories of I wanted to be a doctor because I had such great doctors as a kid. To be honest, I was a high achieving individual throughout school, and I sort of felt like it was an obligation to go and do something bigger than me. And so as I went into high school and college, sciences always appealed to me. I enjoyed, anatomy and physiology and chemistry. And so it sort of felt like a natural fit. Did some volunteering at a hospital during college, realized that, it was kind of a cool place. Sometimes I say I got into medicine having no idea what I was getting into, but I don't regret it. I think that it's been a good use of my skill set. It's allowed me a ton of opportunities, and I've grown tremendously. I'm a much different person today than I was, when I was a 20-something applying to medical school. So yeah, it's not an exciting or wild story, but it was sort of like I felt like it was the right thing for me to do with my life, and I don't regret any of it.
It's interesting that you say you felt obligated to go and do something at a higher power because you were a bright person, competitive, I'm sure, as well in high school. And I know when I first met you, I was like, we are cut from the same cloth. And I actually felt that way for a nanosecond, pretty much a semester in school, but I never wanted to go to medical school. My brother's a doctor. My husband's a doctor. Yeah. My dad's a doctor. But they saw this. In my husband's family, there were no doctors prior to him going into medical school. But like you, he was driven, he was bright, and he was pulled into medical school. Is that happening now?
That's a great question. And honestly, I don't know the answer. I'm not in the sort of undergraduate pre-med side of things to know like how are these students getting into the pipeline? How are they getting interested? I think it's probably very comparable across what students today, what's driving them to medicine.
See, I would disagree with you. I would say what's driving them is Wall Street. And I say that because my youngest son is at Duke, and none of my kids are going into medicine. And he actually told me yesterday that he was dropping neuroscience before school even starts. School starts today for him. And he's dropping it because he said, I decided I'm not going to medical school after my internship this summer, and it's not even on the radar. And he wants to go into the finance world. And he's a math major, and he is very bright, and all of his friends are going into the business side as well. And so I see a shift in those very bright, competitive students who once were drawn to medical school or they felt obligated to go to shift now.
I think there's certainly going to be pull from, the excitement of the financial side of things. And at the end of the day, if anybody said to me, how do you pick what to be when you grow up? My advice is pick what makes you happy, pick what makes you excited. Yes, we all have to make a living, pay off student loans, those sorts of things, but you can't wake up every day and go to a job that doesn't bring you some joy and doesn't bring you some excitement. So, I think there's still a very large section of those high achieving, highly driven people who are still going into medicine, that they're not scared away from it. I don't know the numbers. I know, certainly just out of living it every day, a subsection of my residents are children of physicians or are siblings of physicians. but a lot of them are not. And so I think, you're still getting a lot of top individuals going into medicine. I would argue that there's probably just with the push towards education in general and achievement in general, there's probably just a lot more people that seem to be higher achieving than maybe 25, 30 years ago.
Well, it's funny because my son will say that, oh, Mom, it was so much harder to get into these top schools than it was in your age. And I agree with him to an extent, but I also know how competitive and driven I was. Mm-hmm. But when I graduated high school, there was only one AP class that was offered in my high school. Right.
Same.
Right. My son graduated with 57 credits.
Right.
So it was very different than it is now.
And I think that's a really interesting dynamic change. Like I said, I came from a very small town, a very small high school. We had one AP class as well. It was calculus.
So was mine.
Yep. And I look at, and I have a son now who goes to FAU high school, which is dual enrollment, and he's basically taking junior level college classes as a junior level high school student. So, the opportunities I think certainly have changed. But at the end of the day, I think if you look back and, if you look back at like standardized test scores, they're higher now than they were.
Yes,
previous.
But I was told that you can accommodate it by about 100 points, and it's because we weren't able to use calculators.
I think there's certainly a few reasons. I think some of it is the technology that's available. I think there's probably an aspect of preparation that's different.
100%.
I mean, I won't admit on air the lack of preparation that I had for some of my standardized tests. I still did fine. I mean, I'm here. But comparatively speaking, the level of intensity that I put into some of the things is not quite as high as what the current generation has to do.
Oh my
I
God,
think the pressures are different.
These kids are getting, not these kids, these SAT, ACT tutors are getting like $300 an hour. Yeah. It's insane. And the parents are thinking about this in their sophomore or junior year in high school.
The level of pressure is absolutely different. And I don't know that that's necessarily good. That's a whole other podcast and, probably many podcasts out there about this. But I think that at the end of the day, to your original question, I don't think we are losing the best and brightest. I think there's a lot of best and brightest, and I think there's a lot of sectors that need them, and healthcare is one of them. We need bright people in the finance world. We need bright people in the law system. We need bright people in social services. We need bright people teaching our future students. So I think we're not lacking in the medicine side of things.
That brings me to a point with these cavernous deficits right now for physicians. Yeah. And I shared a statistic with you and you were like, oh, really? And then we started to discuss it. And I want to share it on this podcast. When I was at the Palm Beach County Medical Society gala 7 years ago, I actually was the AMA. It was the American Medical Association president who at the time shared the statistic that it takes 2 millennial physicians to replace a baby boomer physician. So that also has to do with the shortage. We also see a much higher rate of women in medicine as opposed to men right now, or at least going to medical school.
Correct.
And so because of that shift, you also have women who are taking off for maternity leave if they choose to have children. They always, I'm telling you, I would say 98% of the time are the primary caregiver. So they're trying to juggle everything. And so how does that impact residents?
So you mean in terms of like who's picking residency or their experiences or sort of all of it?
Essentially what the coverage is for residency, because we've also shifted in. When you were in school, it was probably, and when you were in residency training, you were probably either post-call, pre-call, or on-call, and that does not exist anymore.
So I think a couple things. Number one, I think the rise of women in medicine, I think, has been made possible by some, tough as nails women who came before us. And certainly I am, I look back very fondly with some of the women who trained me, and they had to overcome a lot of obstacles and a lot of barriers. And, I just want to take a moment to plug. I am a graduate of Drexel University College of Medicine, which is formed by the legacy institutions of Medical College of Pennsylvania and Hahnemann University. And Medical College of Pennsylvania was originally Women's Medical College, which was the first degree granting medical school for women. And so, you know, I love the women in medicine aspect of things, you know, being a legacy student and graduate of those institutions. So I think the fact that we've allowed and made room for women in medicine, I think is super important. To the comment about, you know, needing 2 millennial generation physicians to replace a baby boomer physician, I think there's a few reasons for that. And I think, you know, certainly if you just look at the amount of, I'm going to call it paperwork, even though by paper I do mean electronics, the amount of paperwork that it takes for a single office visit today is astronomically different than it was 25 and even further, you know, 40 years ago. Paperwork, what paperwork, right? You walked into the doctor's office, you paid your fee, you saw your doctor, you left. The doctor handed you some scribble stuff on a paper, and that was it. Today, it's consent forms and scanned license and scanned insurance card and, you know, this liability form and, you know, this consent for this and, you know, the HIPAA release of information. And, you know, so it's all of this extra stuff. And then the visit itself is not just, I'm the doctor, you're the patient, I go over things with you, you tell me what's going on, I tell you what I think it is and what we should do. It's all the buttons I have to click in the computer. It's having an EMR. It's making sure that I've met the quality metrics and the, you know, various MIPS performance indicators. And so the amount of paperwork that the doctor has to do today is very, very different than it was for the, you know, 30, 40 years ago physicians. So why does it take 2 doctors to do that now instead of 1? Because you can't possibly get through the same volume of patients that you used to. And a physician 30 or 40 years ago could see patients in a much quicker fashion, in a much more timely fashion, because they weren't bogged down with some of these other things. So I think that's one of the reasons if I had to, you know, look at it. I think the other thing too is probably rightfully so, some of our priorities have shifted. And, you know, once upon a time, you know, I think back to some of the physicians that I learned from. And there was this one physician, Dr. Oakes, and he was an absolute institution for us. He was an old school doc. He basically had an office that was about 5 blocks from the hospital. He came to the hospital and rounded, walked to his office, saw patients, walked back at lunch, saw people, walked back to his office, saw more patients, and always walked back to the hospital to end his day. He worked 7 days a week. He took all his own calls. He came in on weekends. He was one of the like OG mobile phone people who had like one of those mobile phones that was like in a bag.
Instead of the pagers.
Right? That was after the pagers. But you know, he was telling me a story once about, you know, trying to go watch one of his kids have an event. But he got called to the hospital. So I think, you know, that lifestyle of a physician of being completely 100% dedicated, devoted to your practice, we've shifted away from that. And I don't think that's necessarily bad because, you know, I think physicians of that age, that was the expectation, that was the norm, and we don't expect that today. So I think that, you know, physicians today, myself included, you know, we try to make time for other parts of our lives, whether that's our families, our interests, our own self-care, and you know, other hobbies. So I think that that's a good shift away. But to your point, the amount of work that somebody could do previous as a single individual when they were 100% all in is different than what somebody can do today.
Well, it's funny that you talk about the we and you put yourself with the millennials because I would not put you with the millennials. You're a Gen Xer.
I am a Gen Xer.
And you also moonlighted through school.
Yes.
And people don't moonlight anymore. Do they?
So I think there's a couple things. So yes, I am still a Gen Xer. I say we only because in today's day and age, I train the next generation of physicians. So I've got the millennials, the
Zoomers.
Gen Zs, I think my kids are alpha. I think that's what it's called. So I have to be mindful of all of those approaches and those mentalities and those the things that are important to them. But I am much more Gen X than anything else. And but I think to the point of moonlighting you asked about. So there's two reasons for that. Number one, I was allowed to moonlight. So we had duty hour restrictions, but they were looser, meaning I could work more hours than what the rules allow today. So if I wanted to moonlight, I could do so, provided that I still didn't violate, my work hours. And I had work hours really in my last year and a half or 2 years of residency, not as much in my first year. But today, in 2025, the rules that are put on us in terms of monitoring work hours for the residents, that restricts how much moonlighting they can do. So that's one reason that you don't see as much of it today. Number two, moonlighting opportunities are not as great, at least for my residents here in South Florida, as they were for me in Philadelphia. And it's probably a couple reasons. Number one, they find other ways to fill those gaps besides using resident physicians. And, some of those gaps get filled by physician extenders, APPs. Some just are covered by the people that already are employed. The other thing has to do with malpractice coverage. So in order to moonlight, like if one of my residents wants to moonlight, they have to not only show me that it's not going to make them violate work hours, but they also have to show me that they have their own malpractice coverage outside of what we provide as an institution. And that's not that easy to necessarily get. When I was moonlighting, I moonlighted within our institution. So the institution still covered me, but they covered me under a separate policy, not a residency policy, but more of an independent contractor policy. And those deals are harder to come by too in terms of that moonlighting coverage.
They are harder, but it also helps supplement the income. And that's what I'm sort of getting to right now, because doctors are graduating with such high debt.
So much debt.
Right? And then if you want to go into neurosurgery, which my youngest had thought of for a nanosecond, actually for about 2 years.
Yeah.
He won't finish until he's 35, and that's if he goes straight through.
Yeah.
And so in my example, my husband moonlighted, and I was the primary breadwinner of the family because residents make no money.
Not a lot of money.
And when we chose to have our first child, he was finishing up his internal medicine residency. And he stayed on, like you, a year of chief residency. And so he moonlighted for the University of Miami and Jackson Memorial during that time because I chose to stay at home. And he had to supplement my income because there's no way that I could have been at home. I don't know how we would have juggled it.
Right. It's, it is the medical education debt situation is huge. When I graduated from medical school, I took out loans to pay for everything. So, tuition and cost of living. I deferred paying my loans when I was in residency. And I'm very fortunate I graduated at a time when student loan interest was low, which is different than today. But on the day that I started paying back my loans, my total that day was $242,000. I'm still paying. I'm not done. But for me, I still looked at it as an investment. I mean, listen, why did I moonlight? I did moonlighting because we needed extra money.
Yeah.
We were pretty poor at times. We figured out ways to make it work.
Just to put things I want to put things into perspective for our listeners. So when my husband in 1996 took his first, he was an intern, right? I don't feel like it was that long ago. Okay, it was 30 years ago. But he only made $28,000 a year.
Yeah.
His salary didn't even cover the rent.
Yes, exactly.
And we were in a 1-bedroom, 1-bath apartment. did not even cover the rent.
And really, even though the residency salaries today are different than that, when you account for the cost of living today, I mean, my residents still, even though they make more than I did in my intern year, I think I made about $35,000 as an intern, they still are in the same boat of struggling. I think the other thing that I'll say about Moonlighting is I think some of this goes back to, at least the way my entire family has been. Everybody hustled. And, I started working as soon as I was really able to. So I was 14, 15 years old, having summer jobs, having babysitting. I did work study in college. I was doing those things because that's how I had spending money, and that's how I had money to put gas in the car. And, my mom was able to get my brother and I an old car to drive. But the deal was we had to maintain it and we had to pay for it. So, you had to hustle. There was no we didn't have an allowance. We just weren't that type of a family. My mom didn't have extra money to give us. So, we had to work. And I think some of that push towards Moonlighting was, I was driven, I was hungry, and
I'm still going with
it.
It's your Gen Xer mentality.
It is.
Right?
I do believe is it because we were hungry.
I went for my annual exam last week, and my doctor said, okay, so Meredith, I read a statistic that wherever he came up with it, he said that those who have a hobby live longer, because he knows that is the way to get me to follow whatever he recommends for me. I think I want to live or can live healthily to 100. So this is my goal in life. And he said, you need a hobby. I said, I do have a hobby. He goes, what's your hobby? I said, I have a podcast.
Yeah.
He said, that's not a hobby.
How could he say that?
I know. See, I said, well, I exercise. He goes, yeah, not really a hobby. I go, what the hell's a hobby then? He said, I play guitar. I play guitar for 20 minutes a day, and that's my hobby. And I said, I'm not playing guitar. I did it in 3rd grade, and I'm really bad, and I don't want to do that. Yeah. So my mentality is, that's a waste of time because I'm not achieving or getting to something.
So I think that's so funny. I just recently met somebody who also has taken up these hobbies and forces themselves to do these 2 or 3 things every day for 20, 30 minutes. Interesting, one of them is learning to play guitar. And then one of them is, I can't remember if it's doing crossword puzzles or something like that.
That's so boring.
But I think it's interesting. I certainly look at hobbies in a different way. And, at some point in time, having a second job was a hobby.
Yeah, that's exactly what I'm saying.
But, I think, at least with my residents right now, I do not have a large number of them that moonlight, but a lot of it has to do with just the restrictions that we have on them of whether they can or can't.
Yeah. So why did you even do internal medicine? So you went through this whole process.
Yeah.
You did 3 years of internal medicine residency. Then you stayed on for a year in chief residency. Yeah. And then you went straight into academia. Yeah. So I'd love to hear why you chose internal medicine and then why you went straight into academia.
So it's funny. When I was in starting 3rd year of medical school, that's your clinical clerkship year. That's the year that you're going and doing different rotations in the major specialties. So my very first was 12 weeks of surgery.
Oh.
And I loved it. I was super excited to get up every day. I loved going to work. I loved the excitement of it. I liked the instant gratification of it. I enjoyed the toughness of it.
I was going to say, what did you not enjoy? I want to hear it.
So to be honest, I think the only thing I did not like was I did think that, some of the culture of it was a little, I don't know, I don't want to say demeaning.
Yes, it is. You're a blonde
harsh.
Hair, blue-eyed
there were aspects
doctor
of it that were harsh. And it was, to be honest, it was generally not directed at me. But when I would see how some of the residents were treated, like if they made a mistake or gave the wrong answer, there was some harshness to that. Now, I grew up sort of taking harsh criticism. I credit my basketball coach for making me a very tough individual. But that was probably the thing that I disliked the most. They would have their M&M or morbidity mortality conference, and they'd talk about a case, and there would be a resident up there presenting how they approached a case that didn't go well, and they would just get like crucified. And I didn't love that, because in my mind, they're still learning. They're not doing these things totally on their own. They have attendings. So that was the one part that I didn't love. But other than that, I really liked surgery. And I was surprised. I didn't think that I would like it as much as I did. I then went through more of the year. I did not fall in love with OB-GYN. I knew I was not going to deliver babies or do that. Psychiatry was enjoyable, but I didn't want to do it forever.
My husband fell asleep in psychiatry. I said, how awful.
That's pretty terrible.
Oh, it's pretty terrible.
Yeah.
Somebody's like divulging their life story and you're falling asleep. He goes, I'm lucky I passed it. He said, I don't need to listen to people's problems.
Was very enjoyable because we did an inpatient psychiatry rotation, and then I did child and adolescent psychiatry.
Okay.
So it was really enjoyable. It just wasn't my cup of tea. I didn't want to do it forever. Peds was fine, but I didn't love having to do things to little kids, and I didn't love having sort of two sets of patients, moms and dads, and then kids. Family medicine was great because, again, it was sort of like a little of everything. Every day was a little different. But then when I got to internal medicine, that's where I met Dr. Oakes and many of the other general internists that I learned from. And I loved the relationships, the team-based approach, the mental exercise every day of figuring out, like, what am I going to do for this person? The problem solving, the mystery of what's going on. And I felt the most at home. And so that was kind of what solidified it for me, was it just felt like I was around my people. I felt comfortable. I felt like it was the right thing. When I was in residency, it was actually kind of funny because a lot of the specialists would say, you should do my specialty. You should be a cardiologist. Why don't you choose critical care?
So I was going to say,
you'd be a great infectious disease doctor.
Why not subspecialize?
So to be honest, I did not love any part of the body that much to just focus on it. And I really didn't want to give up the other parts. I like being a general internist. I like being jack of all trades, master of nothing. But
I've
having
never heard anybody ever say they want to be a master of nothing. But yes, you can be all encompassing in the air traffic controller.
I think some of that master of nothing is my trying to stay humble, that like you can't master this. It's a constant evolution. I am constantly learning. I am constantly growing. But I love having that sort of overall aspect, seeing a patient, thinking about them from all of the dimensions, not having, sort of tunnel vision into one organ system or one disease process. Yeah. And to be honest, the people that I admired and loved the most in my training, both medical school and residency, all with the exception of about, 5 of them, they were general internists. And I was like, I want to be them when I grow up. So that's what I did.
So why straight into academia?
So it's funny, when my mom is a school teacher, and I never thought I would go into teaching. So turns out when I was in medical school, when I was in residency, I had a lot of opportunities to teach. In fact, you do a lot of teaching as a senior resident and as the leader of the team. And I realized I enjoyed it. And I also realized I was okay at it. So I had a couple opportunities handed to me when I was in residency by some of my mentors. And they said, hey, I can't be available for this teaching session. Can you cover it for me? You can watch me once and then I'll just let you do the next one. And of course I was like, you sure about that? But they said, yeah, come do it for me. And that's what I did. And it was fun. and it was exciting. And I enjoyed seeing that moment of recognition that the learner has as you're going over something or as you're explaining a concept or discussing something. So again, it felt natural. I think the other reason that I chose academics was that old adage of pay it forward. I was so indebted to the people that I learned from and the people that trained me that the greatest gift I could ever give them in thank you is to follow in their footsteps and do the same thing. So it just felt natural for me to go into academics, and I haven't regretted it at all. It's been an interesting road. I could see myself doing other things, but really I feel like I'm in the right place at the right time.
I feel like there has to be a lot of bureaucracy, though, in the academic world. So we already face it, and you had shared that the, quote, paperwork is so extensive when you're a doctor, and it's insane. So add all of that paperwork, and now you're adding on the regulations in an academic facility, and I would think the requirements of doing certain types of research.
Absolutely. There's a lot that goes into training physicians, whether that's on the medical school side or the graduate medical education side where I am. But it's a part of the process. And I think to me, it's not too burdensome. You know, it's a necessary evil, quite frankly. And all due respect to you and your husband, I don't know how you have a private practice, because that would terrify me. But yeah, I think the regulatory aspects, the paperwork process, it's a lot. I actually spent my morning before I came here working on administrative things and paperwork, and it's just part of what I do. It's not my most enjoyable part of my job.
Again, no.
But it allows me to still do the other parts, which is the teaching, which is the shaping, which is the career guiding that I get to do with my residents.
So how do you guide people into choosing their career path, whether to go into a specialty or whether to stay in internal medicine, especially if you haven't worked in private practice or you aren't part of a hospital system?
So I came from a very large medical school class. I had 240 odd students in my class, and I came from a large residency program. So I graduated as one of 42 in a class. So big medical school, big residency class. And with that comes a big network of people who have gone into all the different aspects, whether that's private practice, direct primary care, academics, non-medicine jobs, or non-clinical jobs, I should say. So I think I have enough of a network to be able to point people in the right direction to get answers to questions that I can't necessarily answer. One thing I will never do is try to counsel or guide somebody on something that I don't know about. I will point them to the people that can give them those answers. I think the other thing is we try in the residency program to bring in career speakers from different aspects of medicine, private practice, group practices, academics, non-medicine or non-clinical, excuse me. So by doing that, I let somebody else come in and tell them about it. When it comes to me guiding them, I go back to what I said in the beginning. You have to like what you do every day, and it has to bring you joy. So I tell my residents right off the bat, do not pick something because you think you're going to make a lot of money in it. That is the worst reason to do the job. You need to pick something that every day you're psyched to get up and go do it. And even on the hard days, and even on days where you might have something else going on, you're still like, that was cool. I enjoyed that. That was so fun. Because medicine is hard no matter what you do. But if you like it, it makes it less hard. And I also tell the residents to think about the areas of medicine where maybe they tend to be the most interested or gravitate towards. I have a lot of residents that love being in the ICU. And in fact, I have, I think, 5 or 6 of them applying to pulmonary critical care for fellowship this year out of 24. So it's quite a few. They love the ICU. They like the excitement of it. They like the dramatics of it. They like the take a really sick person and get them well enough to hand them off to somebody else and then not be responsible for like the fine details at the end of the hospital stay to get them back home. They just want the sickest of sick. And they like the procedures and they like the, life, death conversation
and they're
stuff.
okay working for a hospital.
And they are okay working because they recognize that in a home critical care life, you a lot of times are working shifts, and they're okay with it because they know that when that shift is over, the shift is over and they get to go home. So the ones who love pulmonary critical care, I'm like, okay. But what I say to them is this. I say, listen, I want you to think about yourself 20, 25, 30 years from now. Are you still going to want to do 12-hour shifts, including sometimes at night? Are you going to be okay if you're in a community hospital where you're the one doing everything, putting in all the orders, putting in the lines, intubating the patients, taking all the phone calls? And if you're not okay with doing that, then you have to also think about, do I need to have, sort of a secondary plan? So sometimes residents will say to me, oh, I'm just going to do critical care because it's 2-year fellowship instead of 3. I really don't like the pulm. I think I'll just stick to critical care. I'm like, no, think about that for a second. What will 65-year-old you want to do?
Oh, retire.
Well, I tell them that's cute, but since I'm not expecting to retire at 65, I tell them not to expect that either. So yeah, I think I try to guide them career-wise towards the things that are going to make them happy, because at the end of the day, with the exception of some of our lowest paid specialties out there, pediatrics, some of the family medicine side of things, the pediatric subspecialties, God bless them all, they're like the lowest paid medical specialties.
The lowest.
But besides them, you're going to be okay. And I'm a pretty open book with my trainees when it comes to finances. And I flat out will say to them, listen, this was my medical school debt. This was my first salary. This is how much my mortgage was. This is what my student loan payments were. And I show them that you can do that. You can do those things. Now, I also tell them, I don't live an extravagant life. I don't drive expensive cars. I don't go on a vacation every 6 weeks. So I tell them the realities of what it is to be me. And I recognize that the choices I've made and the life that I live is not necessarily what some of them will want. But I want them to realize that you can do the things you love and not feel like you're pressured to only go into something that's really lucrative.
I think that you have to balance it. So I have worked for myself now for the past almost 18 years, and I will never work for anybody else again. For those who are in academia, you're always going to have a boss. You're always going to be indebted to doing what the larger system wants you to do. The same if you're in a hospital. But on the flip side, I can imagine that you have a better work-life integration, right? If that's what we want to call it. Or you have a little bit more flexibility than someone who is running their own medical practice, and especially ER. I would think my brother-in-law is a pediatric ER doctor, and he works 12-hour shifts. And the nice thing is he can bulk together 4 or 5 days easily, and be able to have that availability.
I think that there's pros and cons to both. I think I do get a nice amount of work-life integration in what I do. I will say that, as you climb the ladder of leadership and you have more responsibilities, that blurring of work-life integration is a little fuzzier, because if my residents need me, I take the call. If my dean calls me, I take the call. If I'm on vacation, unless I have, completely told everybody I am unavailable, I am still somewhat available. So I think that, even though I am employed and I'm not running a practice, I have the level of responsibility of running a lot of things. So I don't get to just kind of turn it off as much. That's what I said about having a practice. I think the fact that you and Mark have this great practice, and I recognize that is a tremendous amount of blood, sweat, and tears and time, and you give a lot of yourselves to make that a successful practice. I think that's true for a lot of people, no matter what the business is.
Yeah, when we first started, I had 2 full-time babysitters. I had 70 hours of babysitting help a week. It was tough.
Yeah.
And you try to figure out how to make it happen. And I think that has to go back to what you said. You have to love what you do. Totally. And I do love what I do. I like change though. So that was what was fun with me about the podcast. I do a lot of advocacy work. At least I get to chat with cool people like you and be able to more work on uncovering the inner workings of something, because while I put in my 10,000 hours in other aspects, I haven't done it yet on how to fix the system.
I think that no matter what, we all figure out how to make it work. We all figure out how to plug all the holes. I have an incredible mother-in-law who, if she had not functioned as our nanny for 7 years, I wouldn't have been able to do what I did. So yeah, I think we all find our village. We find our ways to make things happen. But yeah, I really believe that you have to have passion for what you're doing, regardless of what that is and who the employer is.
And we're just wrapping out a couple of months outside of July 1.
Yeah.
When all of these residents start. So is it true that it's the scariest time to go into a hospital?
No, it's not true. So, I'll get that right out of the way. It's a myth. So July is actually a super, super safe month in the hospital. And that is because no intern is left alone. So I think that's a really important thing for people to recognize. Hospitals are not just like turning the keys over, walking away, letting the interns, these brand new doctors, been out of medical school all of about a month or two, have the keys to the kingdom and run loose. They are so well monitored and guided, and they are not doing things all on their own. So in fact, there's usually extra levels of coverage in July and August and even into September, because we all know none of us were ready to take over a hospital in July. But we were never alone. We always had those layers of security, probably more layers of security today than when I trained. But still, it's a very safe time. And I think that, you should never be concerned that, it's July, I shouldn't go to the hospital because, it's a bunch of interns who don't know what they're doing. Not true.
So I want to go back to your whole female empowerment section, because you're actually really involved in women's organizations. You have been a part of and you are a part of the American Medical Women's Association and the Association of American Medical Colleges group in the Women of Medicine section. Why is that so important to you?
I think from a representation standpoint, half the population are women. I don't know the exact percentages, but, we're approximately a 50-50 society. So yeah, it's important that the doctors taking care of the population are representative of that population. So I think it's important to have women in the medicine and in the sciences sector. It's important for me to again kind of show that you can do this. I never ever will say that I do it alone. I always give credit where credit's due, which is to my village. I mentioned my mother-in-law because she is really important to how I was able to survive, my first 7-8 years of practice. My husband of 23 years, he's been with me through the entire process, not a doctor, but I wouldn't be able to do what I do without him. And so I think it's important that other women in medicine and in, medicine interested recognize that you can do these things. I think as women, and I won't quote the exact studies, but I will tell you there are studies out there that do look at the quality of care that women physicians and women surgeons provide relative to male counterparts. There are studies that show that female physicians in some aspects have better quality of care in some things. So I think it's an important thing to keep cultivating and keep growing. And I will tell you that there are many women that I've taken care of in my life who are so happy to have another woman take care of them.
Well, it's interesting that you say that because 55% of new medical students are actually women. Yeah. And that is for the 6th consecutive year that there's been a predominance or a higher percentage than 50% of new medical students as women. And I really would love to hear what you think that shift is, because if I were to go back 30 years ago, only a third. So 30 years ago, my husband went into practice. Only a third were women, and now we're more than 50%.
Yeah, I think it's a couple things. I think certainly there's been a big push to encourage girls and women into STEM fields. Mm-hmm. So I think, way before they get to me, I think there is that push and that encouragement. And I think it's kind of one of those sky's the limit, like go for it. So I think we're empowering them earlier. And I think they are realizing that, I can do this. And I can, not to be cliche, I can have it all. So I don't know if those numbers will shift back. I believe the pendulum does exist.
I think women
kind of
have realized
everywhere.
We can't have it all, actually.
I know. And that's why I actually don't like that phrase too much, because I think that I think of it as spinning plates. Right? So if I'm spinning a whole bunch of plates, some of my plates spin better than others. And sometimes I have to go and
hopefully some don't crash and burn.
Right. And you just have to know which of your plates are the plates you can't let crash. And so if like, for example, you talked about hobbies. If my hobbies plate crashes for a while, which it did for probably 20 years, it's okay. That's not a big deal. But I can't let my family plate crash.
Correct.
I can't let my best friend's plate crash. I can't let my husband plate crash. I can't let my health plate crash. But if I stopped reading for 20 years and just recently picked up reading again, well, that's okay, because I have the bandwidth to be able to spin more plates.
I think that's a really great perspective, because I went back to graduate school for the second time when my youngest was 3 years old. And being able to, I lasted 3 semesters and I had to leave because I could not run our medical practice because that plate could not fall, because that's what pays our mortgage.
Correct.
I could not have my marriage fall apart. Mm-hmm. I could not have my children fall apart. And the only thing I could give up at that particular time was school. Yeah. I was already giving up any of my workouts to begin with because I was trying to figure out how to make it happen. And then you look at health, right? I think you have to rank priorities and figure out what's important to be able to keep spinning. But I really like that analogy. In a recent episode, and I really want to ask you this, I interviewed Preston Alexander, and he has an MBA. We talked all about the business side. Okay. And one thing that he had shared was, I wish doctors could learn more about the business side of medicine. And my question to you, and I even said, I have somebody coming on the podcast, I'm going to ask her. And I fought back and said, where are you putting it in their curriculum?
Yeah.
So my question to you is there room in the curriculum to talk about the business side? And if there isn't, is there anything that you think is missing in the curriculum for med students where you got your residence and you're like, oh, thank God they had this course?
Great question. The business of medicine is super important, because even in academics, I still have to worry about the dollars and cents. I still have to worry that the doctors that I employ are seeing enough patients, billing appropriately, meeting their quality metrics, getting proper reimbursements from insurance companies, that our collections are good relative to our charges. So business of medicine is really important. But where do you put it? I think that's the challenging question. I don't think there's anything that we can jettison from the medical curriculum for medical school to put it in place. What I would argue is have little bits of it, which I think many medical schools have some elements of business of medicine involved in the 4-year medical school curriculum. I think then in residency, again, intersperse aspects of business of medicine. But to be honest, a lot of the business of medicine, I think you have to kind of learn when you're working and when you're in a practice. Now, if I have a resident that says, I really want to figure out how to open a practice, well, I'm going to counsel that person very specifically about what I think they should look for, who they should talk to, what additional trainings, et cetera. If I have somebody that's going to be employed, well, they have to learn business of medicine in a slightly different way, but they still need to understand it, right? Because if you're employed, the business of medicine that you need to understand is how does my documentation and my billing and coding affect the bottom line that ultimately pays me. So I think business of medicine is not, it's not one size fits all. I think it has to be tailored. And that's why I'm not sure there's like one set place that it belongs in a curriculum. I definitely don't think you can teach an entirety of business of medicine during a 4-year medical school curriculum. There's just not time. And I would also say, depending on the type of practice somebody's going to go into, not everybody needs the same level of it. So that's why I said I really think it has to be more on the job, and it has to be relevant to the job that you're taking and the job that you're doing.
Is there anything that's missing from medical school curriculum where you really wish your residents came in with a little bit more knowledge on?
So I think one of the things that I think is very different today than when I trained and when your husband trained is I feel as though I was probably allowed to do a lot more hands-on practicing and a lot more, and I had a lot more critiquing of my hands-on practice than is happening today. Now, that's not for lack of trying, and that's not for lack of trying to incorporate activities and clinical skills activities, et cetera. I just think that some of the patient expectations today are different. When I was a medical student, I very, very rarely was turned away from a room. I was very seldom told by a patient, I'm not talking to you. And I think that's a little bit different today, where patients, don't always love having students. They don't necessarily recognize the importance of that patient's impact on a student's education. And whenever I have students with me, and even when I'm with my residents, I make sure that the patient understands that, first of all, nothing they are doing is without my guidance and is without my oversight. But also that in order to be me, I had to be them. And you can't get good as a doctor if you don't try things a lot of times and practice things a lot of times. So I think, to me, the thing that students today come out, with less of is just those hands-on experiences.
And I think also it would have to do with tort reform and liability.
Yes, probably has a role in that.
We have residents in our practice, and we're in private practice, and yes, the level of expectation of our patient is much higher than if you're in an academic facility, and they do not want the resident touching them.
Yeah.
But if you were and you were at Drexel and you were working in hospitals in the city, and when my husband did training and he was in medical school, at the University of Florida, he had to go to Jacksonville and he had to do some rural medicine, and people were not given as much of an option, right? And then with training at the University of Miami, it's a free for all, or it was back then with Jackson Memorial Hospital and the county hospital. But your perspective is very interesting to me, because yes, I think expectations of patients have changed, but I will also say we're having issues because we are so litigious.
Of course. And it's a challenge that you have to figure out how to overcome it, though.
We do, so that we can actually train the doctors properly.
Because it's not the same if I take a student, or if I take a resident and I have them listen to heart sounds on a computer, or I take them to the simulation center with a high fidelity mannequin, it's still not the same as human beings. And it's not the same as, hands-on touches. So I think we have to figure out how to do more of it. I am a huge proponent, and I do this with my residents a lot, of I'll walk in as they're doing things and be like, just keep going. Now, it's very interesting because they're very uncomfortable when I walk in the room, probably because I'm their boss.
Yes.
But they're like, oh, okay. I'm like, no, just keep going. It's fine. So I think it's important that they get used to that more. I laugh because when I was in medical school, and Mark probably had this too, we literally had a VHS cassette with our name on it, and we had to bring it every time we went to the clinical skills center. And we had to, they would videotape us. We would get our tape back. We would have to watch our tape. We'd have to write a critique of ourselves. It was so helpful. It was incredibly useful to watch how we interacted and how we did things because, how often do we do that? So I think if we can keep pushing some of those observed experiences, the only reason that I have gotten good at what I do is because I did it a lot of times and people gave me critique on it. Because if I didn't know how to palpate a liver correctly, well, somebody showed me.
Well,
and they corrected me.
And hopefully those who are getting critiqued are learning how to take that criticism or that guidance.
Yeah.
Which is a whole, again, different podcast.
Yeah. But I do think that most of the time, learners, listen, everyone goes to medical school, like they're high achieving individuals. They want to get A's on tests, right? Like I always say that, like I'm a goal oriented person. I want to get an A on the test. So do all the current learners. So they want to perform well. So they do take that criticism and that critique. I think that we just have to be mindful of how we give that critique. And that's a little, I'm kinder and gentler today than I probably was 15 years ago, maybe even kinder than I was 5 years ago. But I think that it's important to recognize that the doctors of today coming out of medical school, they are still very well prepared. They are still very capable of starting on July 1st and being successful in a training program, whether that's internal medicine or surgery or radiology or dermatology or pediatrics or whatever. They're capable of doing it. And we know that they are because they're coming from schools that are accredited and they have to meet certain benchmarks and certain metrics. So I know that they're prepared. Do I have a different sort of set of expectations and goals for them than maybe were put on me when I started my residency 20 years ago? Yes, but medicine's also different today than it was 20 years ago. And I think when we go to the doctor, we have different expectations today than we did 20 years ago. So I think the educational piece is just an evolution as well.
So I'm going to ask you my final question.
Okay.
If you could create one change within our American healthcare system, whether it's the educational side or the entire entity, what would it be?
I think for me, it's access to care. I think it is the part of the healthcare system that makes me the most worried, the most sad, because in healthcare, we are haves and have-nots. And, really what it comes down to is it's insured or uninsured. And if you are in the uninsured bucket today, it is potentially catastrophic if something happens to you. And if I could make one change, I would figure out how do we make sure that regardless of your ability to pay a bill, that you can get the health care that anybody should be able to have. It should not be that patient A gets one thing because they can afford it and patient B gets something else because they can't afford it.
Well, I'm going to take it one step further and say it's not just those who have health insurance and those who don't. It's the type of health insurance that the person has as well.
Of course. And that's, again, you probably have other podcasts that are just about the insurance aspect of things. But again, I went into medicine because I felt like I had a lot to give. And I felt like I could go into it and be, caring and loving of all and provide great service to everybody. And I strive to do that. I will say it's one of the other reasons why I like being in academics because, I do have that ability to kind of serve all. But I didn't go into it thinking I would have to treat people differently based on whether or not they can afford something. And, yes, to the point of insurance levels vary, but if I could figure out one change, it would be that everybody can get what they need when they need it, regardless of the cost.
Well, Dr. Allison Ferris, this was insightful. I learned a lot. I had a great time just discussing what's going on with all of these new interns.
Thanks, Meredith. It was a pleasure. Thank you so much for having me.
To everyone listening, the full video of this episode is now on YouTube. Search Working Healthcare and hit subscribe so you don't miss future interviews, short clips, and behind-the-scenes moments. Got a question, an episode idea, or someone you think we should feature? Drop me a line at meredithhirsh.com. And if this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. You can also follow Working Healthcare on Instagram, Facebook, and YouTube, and connect with me on LinkedIn. That's where we keep the conversation going in between episodes. The more voices we bring into this space, the more momentum we build, because change doesn't start with a policy. It starts with a real conversation like this one. New episodes drop every Tuesday. Subscribe and don't miss what's next, because you can't fix U.S. healthcare until you understand how it works. Tune in weekly as we explore the inner workings of healthcare.